Hello, my name is Dr. Shehzad Ahmed, resident orthopedic surgeon, Khyber Teaching Hospital, Peshawar. Under the supervision of Professor Dr. Muhammad Shuaib, Dr. Syed Dilbagh Ali Shah, Dr. Abbas Ali, and Dr. Imran Marwat. Supracondylar humeral fracture. In this video, we will discuss supracondylar humeral fracture and its operative procedure. Guys, kindly subscribe my YouTube channel. What is supracondylar fracture of the humerus? It is a fracture of the distal humerus just above the elbow joint. The fracture is usually transverse or oblique and above the medial and lateral condyles and epicondyles. Supracondylar fracture of the humerus is one of the most common traumatic fractures seen in children and most commonly occur in children 5 to 7 years of age from a fall on an outstretched hand. It is mainly diagnosed on plain radiograph. The treatment of supracondylar fracture of humerus is usually closed reduction and percutaneous spinning, with the urgency depending on presence or absence of hand perfusion. 95 to 98% of the fracture or extension type on presentation. Flexion type is very rare and presents in less than 5% of the cases. The mechanism of supracondylar fracture of humerus is fall on outstretched extremity. There are some associated injuries with supracondylar fracture of humerus, including neuropraxia of anterior interosseous nerve. It is a branch of median nerve. Neuropraxia of anterior interosseous nerve is the most common nerve palsy. The second most common neuropraxia is radial nerve palsy in this type of fracture. While the ulnar nerve is most frequently injured in flexion type injuries in 10% of the patients, obese children have been shown to have a higher rate of both preoperative and postoperative nerve palsy and higher rate of open reduction. A loss of neurologic function after reduction is concerning for nerve entrapment at the time of reduction. An urgent open exploration of the nerve is necessary. Most nerve injuries are a result of neuropraxia and resolves within 6 to 12 weeks. Electromyography is indicated if there is no return of nerve function within 3 months. Urgent assessment of the vascular status of the limb also is essential to minimize complications. A vascular injury, typically to the brachial artery, can occur in up to 10 to 20% of patients with a type 3 fracture. Because of the rich collateral blood supply about to the elbow, the hand may be well perfused, even with complete disruption of the brachial artery. The vascular status of the limb can be classified as normal, pulseless, but with a warm pink perfused hand, or pulseless pale non-perfused hand. Treatment of the patients with a pulseless warm hand remains controversial in terms of the need for brachial artery exploration. Supracondylar fracture with a non-perfused hand is a surgical emergency to prevent reperfusion injury and compartment syndrome, leading to Volkmann ischemic contracture. Compartment syndrome occurs in approximately 0.1% to 0.3% of patients with supracondylar humeral fracture and is more common with concurrent fracture of the forearm and wrist. In pediatric patients, the 3 A's, agitation, anxiety, and increasing analgesia, are sensitive and reliable indicators of impending compartment syndrome. In patients with vascular compromise, urgent reduction in the operating room should be performed and the vascular status of the hand assessed. Arteriography should not be used unless the level of vascular injury is unclear in patient with polytrauma and should never delay close reduction of supracondylar humeral fracture. If perfusion is not restored, urgent exploration of the brachial artery with release of entrapping structures and direct repair with vein grafting, if necessary, should be performed by a surgeon with experience in the repair of small vessels. Prophylactic forearm and hand fasciotomies are necessary in patients with prolonged ischemia time. This is especially important in patients with concomitant neuroinjuries in which the ability to detect compartment syndrome clinically is impaired. Most patients in whom perfusion is restored, pink hand, even in the absence of a radial pulse, have a good long-term outcomes with observation. Gartland classification of the supracondylar fracture of the humerus. Type 1 supracondylar fracture is non-displaced fracture and is treated with cast immobilization for 3 to 4 weeks. Type 2 fracture displaces in one plane. Posterior cortex and posterior periosteal hinge in type 2 supracondylar fracture is intact. Deformity is in the sagittal plane only. Type 2 fracture is typically treated with close reduction and percutaneous pinning. Type 3 fracture is displaced in 2 or 3 planes and is treated commonly with close reduction and percutaneous pinning or open reduction if needed. Type 4 fracture is complete periosteal disruption with instability in flexion and extension. It is diagnosed with examination under anesthesia during surgery. Type 4 fracture is treated most commonly with close reduction and percutaneous pinning or open reduction if needed. Treatment of supracondylar humeral fracture is based on the Gartland type. Type 1 fractures are treated with long arm cast immobilization for 3 weeks followed by a brief period of protected activity. Patients with the presence of a posterior fat pad on radiographs should be presumed to have a type 1 fracture and treated in this patient. While treatment of type 2 injuries is somewhat controversial, Wilkins subdivided type 2 injuries into A and B, with type 2A fracture being stable and type 2B fracture having some degree of rotation or translation, making them unstable. Closed reduction and casting can be used in patients with type 2A injuries. Closed reduction and percutaneous pinning, typically with 2 or 3 lateral pins, has become the main form of treatment for type 2B injuries and for those in which the stability is in question. Pinning is preferred for most type 2 fractures because of concerns about the ability to maintain reduction in a splint or cast. Poor patient compliance with barriers to timely follow-up and difficulty in differentiating between type 2A and B fractures. Type 3 and 4 fractures are treated with close reduction and pinning. Complications of percutaneous pinning occurs in approximately 5% of patients, with pin migration or irritation being the most common, followed by infection and elbow stiffness. In this patient, we have done close reduction and percutaneous pinning with 2 crossed or 2 lateral pins. This is an image intensified showing a pin passed from medial side. Fluoroscopic image shows transolecranon and laterally based Steinman pin.
اوس کې څه ویل دا خالد صاحب دا بل بکو ها
راځه راځه
څه وایي ته وایه وایه نه بې ځایه وایه اصل کې ما کې په ماسک باندې
لاس لږ ورخوا که بهر که لاس ټیپ ته دلته لاس لږ بهر که
ته وایه
ټیپ ته لږ ورشي دننه
اوس وایه وایه
ځه دا به کته دا به کټ کړو کنه
ها
دا څو ګوره به کټ کړه
او
کټ کنه بیا به کړه د زور زیاتو چې کوم انسان دی
نماز ټایم نشته کنه
یا سلیب ټیک نه دی ازول لاس ولا سلیب نه لا نه فټ کیږي زه تر راته وکړه زه راته وکړه تم ولا دا وکړه تم ولا پرې تم کې بار زه لاندې راځم اوس لاندې دلته به یو پیر راغلی وي زه ټیک یم
واټ کې چې هغه شولډر دی واټ کې به ټرای کوي که
نه نه دلته به راولو او خو ویني کې کنټراکچر دی
شولډر ډیسلوکیشن دی
مړه کې هیڅ ضرورت نه بس
ټاول ورته اچو ما کنه ټاول چورته واچي
نه نه په اریو کې بیا چې صرف
نه نو دغه ته په کالو کوم واټ ته چې
او دا وی راویلی
خو انډیا موسم
بس را لېږه هغه کې هیڅ څومره دي دلته به لږ راغلی و که نه زه ټیک شو
تو په لیکل خو نه یې که نه
نه نه
چې لیب ځینې شي نو هغه
هیڅ ضرورت نه
لیکلې وي خو